the case? How does that work?
Laura,
I
can you
think we
help?
can turn it on and off. It's just that when we post it, it'll be multiple videos. We won't be able to crush it into.
Okay, that's okay.
Such a big deal.
It
It won't be easy to watch.
I mean, maybe what I could do is give a generic, rather than show my slides with the specifics about patients, I can give a generic scenario. I think that would be good. Because we had a discussion at our Be More Collaborative meeting, and it was like really interesting in terms of some of the nuance based on pathophysiology. Like there's guidance, but there's a lot that we don't know. And I found that part of the conversation really helpful. So
No, I agree. This is definitely a devil is in the details problem. And so like those details that come out from a clinical scenario are super helpful.
yeah. Okay, is Ricky on? I know that is she still planning on joining?
Yeah, she is. Let me just.
Okay.
Okay, so welcome to everybody who's joining. I'm going to turn it over to Joyce and her team of star presenters to take us through today. And I'm actually forgetting what next. Oh, next week I believe is Bartlett updates and cases. So,
Thanksgiving.
Oh, sorry, next week is Thanksgiving. Happy Thanksgiving. I'm thankful for all of you. And I'll turn it over to Joyce. Joyce, you're muted.
Oh, I thought it was me.
Thank you, Eileen. Maza, maybe just let me know when Ricky has joined.
She's joining a little bit late, but she'll join in a couple of
Okay,
minutes. So
super.
I think we can begin.
Okay, great.
All right.
Yeah, do you want to introduce yourself?
Sure.
Maza? Yeah.
Sure. My name is Abdi. I'm one of the lead partners for the High Resolution Anoscopy Center for the early detection of precancerous lesions and treatment of the anus. And we're a multidisciplinary clinic. Myself, we have Bridget Morris, who's our nurse practitioner, Dr. Buchwald, who's our infectious disease expert, along with Joyce Jones. And we also have some colorectal surgical partners. And so it's a pleasure to talk today and review some of the newest anal cancer screening guidelines and discuss some few cases. Thank you, Eileen and Joyce, for inviting us. So I will begin. I wanted to, let's see. I have no disclosures. And so I'm going to be reviewing the new anal cancer screening guidelines and discuss screening modalities overall for anal dysplasia. I wanted to quickly talk about some of the background information about anal cancer and dysplasia. This is American Cancer Association and CFAR data, just showing that the anal cancer estimates for this year are that there'll be 10,540 new cases. The incidence rate has increased by 2.2 to 2.7% per year. That risk has risen in high-risk populations. For the incidence of anal cancer in specific risk groups, this is Clifford's meta-analysis providing comparable estimates of anal cancer among high-risk groups. And it shows that for anal cancer incidence on the left per 100,000 person years is highest in HIV positive MSM, HIV positive men and women, and gynecologic cancers, especially vulvar cancer, and renal transplant greater than 10 years. So that important risk factors for anal cancer, just to remind you, are persisting HPV infection, history of vulvar, vaginal, and cervical cancer, or high-grade disease, anal genital warts, multiple lifetime sexual partners, receptive anal intercourse, immunosuppression, including solid organ transplant, HIV infection with low CD4 nadir, high viral load, and tobacco use. For most anal cancers are due to HPV, and so for anal-related cancers, the carcinogenic subtypes I've listed here for you that include 16 and 18. for low persisting HPV infection with a high risk HPV type is a prerequisite for the development of squamous cell cancers, and HPV subtype 16 and 18 are responsible for 85% to 90% of anal cancers, 70% of cervical cancers, 20 to 50% of head and neck cancers, and 40% of vulvar and vaginal cancers. This is just discussing the histological and natural history of anal dysplasia. So the last lower anal genital squamous terminology project gave a consensus paper about terminology for describing squamous lesions associated with HPV. And there are two main categories: low-grade squamous intraepithelial lesions, or LSIL, and high-grade squamous intraepithelial lesions, or HSIL. And so abnormal lesions include low-grade dysplasia, such as condylomas and AIN1, which are due to low-risk HPV types like HPV 6 and 11, and also divided into high-grade squamous intraepithelial lesions, which include AIN2 and AIN3, which are due to high-grade subtypes of HPV, including 16 and 18. And that HSIL is a precursor development of cancer. And when AIN3 invades into the basement membrane, you can develop microinvasive cancers. So the ANCHOR study showed that screening and treatment for HSIL does reduce cancer risk. So just to remind you, it's a multi-site randomized study with 4,446 men and women with HIV older than 35 years of age being recruited into the study. They had to get biopsy-proven HSIL, and they were randomized into two arms, treatment arm or active monitoring arm every 6 months. 9 patients developed cancer in the treatment group. 21 patients developed cancer in the active monitoring arm, but the overall rate of progression to cancer was significantly lower in the treatment arm by 57%. So the topic of this talk is to discuss the new anal cancer screening guidelines. So there are 3 that we'll review for today. The International Anal Neoplasia Society Consensus Guidelines for Anal Cancer Screening that came out in January of this year. The NIH, it's NIH and CDC, and I think IDSA had a group, but consensus guidelines for prevention and treatment of opportunistic infections in adults and adolescents with HIV that came out in July of 2024. And then older guidelines from 2022, the New York State Department of AIDS, of Health, AIDS Institute Clinical Guidelines Program. Okay. So first we're going to touch upon the IANS consensus guidelines. And so first they started by describing who should I screen for anal cancer and neoplasia, cancer and dysplasia, and at what age should we start screening. And so the screening populations are divided into 2 risk categories, category A and category B. For category A, which is the highest risk group, those are patients that have an incidence of developing cancer that's greater than 18 per 100,000 person years, which is also more than a 10-fold higher risk of developing cancer compared to the general population. So for this group, the highest risk group are people living with HIV. For people living with HIV, men who have sex with men, screening starts at the age of 35. For transgender women living with HIV, screening also starts at 35 years of age. Also in high-risk category A include other people with HIV, and screening starts in that group at 45 years of age, and that includes women with HIV, MS, men who have sex with women with HIV, screening starts at 45 years of age. Also, MSM, not with HIV, transgender women not with HIV are also in high-risk group A, and they start screening at 45 years of age. 2 other important groups to remember are solid organ or other forms of immunosuppression and history of genital cancers or dysplasia. So for patients who've had a solid organ transplant, screening initiation begins 10 years post-transplant, and that's also starting at the age that starts 10 years after their transplant at whatever age. For patients with a history of vulvar cancer or precancer, screening initiation is recommended within 1 year of that cancer or precancer diagnosis. So next, we're going to talk about risk category B. So that's also an elevated risk group, but not to the level of 10 per 100,000 person years. So they have a little bit under a 10-fold risk of developing anal cancer or dysplasia. Sorry about that, compared to the general population. This involves a shared decision-making, provided that you have adequate capacity to perform HRA, and that starts at 45 years of age. That group includes a history of cervical and vaginal HSIL or cancer, perianal warts in men or women, a persistent cervical HPV-16 infection defined as greater than a year, and then other immunocompromised patients like rheumatoid arthritis, lupus, inflammatory bowel disease on steroids, especially greater than 10 years. So going over screening modalities for anal dysplasia, of course, they include digital anal rectal examination, so don't forget to do that. Ian's also has a nice little paper about digital anal rectal examination, and make sure that you're going into the rectal vault, that you're palpating in a 360-degree motion or 4 quadrants, so that you're getting the whole anal verge and the anal rectal ring. A history is also important. Finding out if patients have anorectal symptoms, getting a good sexual history, and identifying risk factors in their history are important. And of course, other screening modalities or cytology, HPV testing, and an HRA. So Ian's also talked about management for depending if you have an abnormal PAP and HPV test. And remember that management varies depending on if you're only able to screen with a PAP test versus a high-risk HPV test or combined co-testing. Management can be modified if you're in a limited resource area for HRA. And so for your screening results, if you have a cytology that is normal, your high-risk HPV testing is also negative, management is to repeat screening anywhere from 12 to 24 months. If cytology shows ascus and your high-risk HPV testing is negative, you can repeat screening in 12 months. If cytology is normal, but your high-risk HPV is positive, it is up to the provider to decide if you want to refer for an HRA or repeat screening with your co-testing in 12 months. And that also includes a normal cytology, a normal PAP, with a high-risk HPV positivity with a non-16, non-18 type. Moving on to LSIL. If your cytology shows LSIL and your high-risk HPV testing is negative, it's also up to the provider discretion if they want to refer you for an HRA or continue screening at 12 months. The patients that are always going to go to an HRA are those with ASK-H or LSIL and a high-risk HPV positivity. And remember, if you're HPV-16 positive, regardless of your cytology, you're going to go straight to an HRA. And for patients, of course, with cytology showing HSIL or ASK-H, regardless of their HPV testing, are also going to go for an HRA referral. I just wanted to put, in case we are also treating patients in a low HRA resource area, I just wanted to include the screening and management guidelines. So for patients who have a normal cytology and a negative HPV test, they can repeat screening in 24 months. If you have ascus and also an HPV negative test, you can repeat screening in 24 months. If cytology is normal, high-risk HPV is positive, you can repeat screening in 12 months. If your cytology is normal, your high-risk HPV is a positive, a non-16, non-18 subtype, repeat screening in 12 months. If you have LSIL and cytology, high-risk HPV testing negative, repeat screening in 12 to 24 months. If you have ascus or LSIL with high-risk HPV positivity, you can repeat screening in 12 months. And of course, for HSIL or AskH on a cytology, regardless of HPV testing, you're going to refer for an HRA, and HPV 16 positivity, regardless of cytology, goes for an HRA. I just wanted to bring your attention to that Ian's, because there's a little bit of debate between different guidelines, I just wanted to bring your attention that Ian's also addresses specifically screening modalities. So if you are in a center that only has cytology or only has HPV testing, there is an algorithm for that too. So if you have normal, if you only have cytology at your clinic, and you have a normal cytology in a high resource area, you would recommend repeat screening with your cytology in 12 months. In a low resource area, you can repeat cytology in up to 24 months. If cytology shows ASCUS or anything more than that, then you would refer to an HRA. And in a low resource area, if you have ASCUS or LSIL, you can repeat that testing in 12 months. And of course, if you have HSIL or AskH, you would refer the patient for HRA. If you are in a clinic where you only have HPV testing, and you're in a high resource area, if your high risk HPV testing is negative, you can repeat screening in 12 to 24 months. In a low resource area, you'd repeat screening up to 24 months. And if high risk HPV testing is positive, you refer for an HRA. In a lower resource area, you can, if they're positive for a non-16 type, you can repeat in 12 months. If it's 16 positive, you'd refer for an HRA. And so the Office of AIDS Research also has guidelines that address many things, including prevention and HPV vaccination, risk factors for anal cancer, including age and duration of HIV. They discuss digital anal rectal examinations and cytologies and HPV testing and HRA. And overall, they do agree with Ian's consensus guidelines for anal cancer screening, for who to screen, the age to screen, and the general screening algorithms. They also support anchor study for office-based ablation. However, the guidelines do differ in the use of HPV testing and additional risk factors to prioritize who needs that HRA. So the differences are that Ian's does support primary HPV testing alone without a cytology as a screening option, but for the Office of AIDS Research does not, given that HPV positive, given that HPV is pretty prevalent, right? 70 to 90% of us are exposed to HPV over our sexual lifetime. And so it doesn't have a good predictive value. And so they do not advocate just sole HPV testing. Other differences are that the NIH guidelines prioritize patients with the following risk factors for an HRA. So a higher grade of cervical abnormality, HPV 16 testing, which is similar to Ian's, but they also advocate prioritizing HRA in patients who are smokers over the age of 60, have a longer duration of HIV, and a history of AIDS. I just wanted to also quickly review how to perform a Pap test. You're going to insert a Dacron swab into the anal canal, pass the SCJ. You're going to lubricate with water and not jelly. You're going to rotate the swab vigorously to acquire cells and place it into your Pap medium. Before you want to do your Pap testing before a digital anal rectal examination or a lubricant or STI testing. You want to tell the patients to refrain from enemas, douchings, or anal sex 24 hours prior to your examination. And we do have HPV co-testing with cytology available, and you just have to enter lab 54698. I know that a couple of folks have asked me about self-collected specimens. And I know that I think Ricky and Joyce were talking about this too at their last meetings. And so I did find a study that's going to be published in January in the International Journal of Cancer that is a meta-analysis evaluating HPV and cytology and compares a self-collected versus clinician-collected anal swab. And I just showed the forest plot that looks at sampling adequacy, and it is similar for clinician and patient collected anal swabs for HPV, certainly, and overall for cytology. In this study, the primary outcome was to look at HPV and cytology sampling adequacy. There were some secondary endpoints looking at acceptability of the collection methods. And just to note that in the self-collected cytology specimens, that even though it was comparable, it was slightly lower for cytology in the self-collected arm by about 10%. And then I also wanted to touch on the New York State guidelines. And so the New York State guidelines address a lot of things: screening, prevention, following up abnormal cytologies, treatment of HSIL. They do a little overview of anal cancer too. And for their recommendation is that for adults, all adults greater than 35 years of age who have HIV, need to have testing. So that includes men who have sex with men, transgender women, transgender men, and the screening should be an annual Pap test to look for cytologic abnormalities. And then this is the algorithm they use for screening, which is what we've used in the past, so that someone with normal cytology a normal cytology will have an annual Pap test. Someone with LSIL or HSIL will go to perform an HRA. Patients with the difference in this guideline is for patients with ASCUS, and for ASCUS they do endorse high-risk HPV testing. So if everything is normal, you can just screen them in a year. If they have LSIL or HSIL, they go straight to an HRA. But for patients with ASCUS, they recommend HPV testing. And so if high-risk HPV testing is negative, then they can go to an annual cytology. If high-risk HPV testing is positive, then you would perform an HRA. And so in conclusion, it's important to perform a digital anal rectal examination for anyone with anal rectal symptoms. You want to screen high-risk groups with anal cytology and HPV testing. The patients that need early screening at the age of 35, your highest risk category patients are obviously MSM with HIV, transgender women with HIV. Other people to screen starting at the age of 45 include people living with HIV. For patients with ASCUS, you do not have to refer to an HRA. You can repeat screening with your cytology and your HPV testing. Anyone with HPV 16 and ASK-H go straight to an HSIL, go straight to their HRA. And for patients with LSIL, it's really up to the provider's discretion if you want to bring them for screening in a year or refer them for an HRA. And of course, HPV vaccination and tobacco cessation are important preventative methods. So thank you very much. I've just included how to order, I know everyone knows, but how to order an HRA. Tanisha Robinson is our medical office coordinator, so I've included her direct phone number, especially if you're having problems with ordering your HRA, or if there's a long time for the HRA. You can also directly email me or Dr. Buchwald. And I just also wanted to bring up that we are working over the next year on novel treatment options for treatments of our patients with persisting HSIL. Joyce has graciously helped me with getting some new equipment, and so hopefully we'll be starting sedation HRAs and aggressive treatments in the future. The other things that we're working on is the artesunate study. The FDA granted us a compassionate use trial for patients who have persisting HSIL that have failed therapy. So they failed surgical therapy, they've failed topical therapy, they've failed office-based ablation. We're recruiting patients for artesunate. And then we're also working with gynecology for an HPV therapeutic 16 vaccine. So we have one patient enrolled in that study.
That was awesome, Maza. Thank you so much. I see Dr. Buchwald also joined. Ricky, I don't know, do you have video capability?
On video right now.
Okay. Or
Yeah,
just audio.
Thank
Do you
you.
want
Sorry for joining late. My other meeting went over, sorry, but thank you, Maza, for the review.
do you want to introduce yourself as well?
Yeah. I'm Ulrike Buchwald. I'm one of the providers in our HIA clinic. I had previously done HIAs at the University of Maryland, and then 2019, thanks to the help of Joyce and others, transferred to gastroenterology, and was able to recruit Maza and Bridget for our wonderful clinic. But I'm infectious diseases physician by training, and I work full-time actually in the pharmaceutical industry, but I very happy to do this as my clinical specialty, and really happy place. Thank you everybody who works with us on this important. It's a very important topic, and just recently a patient of mine called me and he said, well, I dropped out of care for 5 years and now I have anal cancer. So it does happen.
Yeah. So what we could do next is maybe present some of the workflow that we have put together, and then we can I have a few cases that we can review, and then we can have some time for questions. So Randy Bornmann is here. He worked with me to update our Bartlett workflow. That will give us just sort of the guidance for providers for how to do things from the clinic. And we can review some cases, and then we can have some discussion.
And Joyce, I just wanted to mention there's 2 questions in the chat. They may be covered in Randy's part. So from Barb Bogus, for patients without insurance, is there Ryan White coverage?
So Barbara, everybody who is living with HIV can be insured. So we can either through Medicaid or through MADAP. MADAP will pay premiums for people who and obviously this is for people with meeting the financial criteria, but MADAP will pay the premiums for insurance. So in general, with Ryan White, we use funds for things that need to be addressed right away and can't wait until insurance can be secured. But for this kind of procedure, we get people squared away with insurance, and then we do our referral. And then Dr. Abdi, there's Pat Bardich asks, any recommendations if there's no glandular cells present on the cytology? What are your feelings about that with the anal pap?
Yeah, you don't need to have glandular cells to get an adequate pap specimen. So as long as it says that there's no epithelial cells, then it's a negative pap test. And there is definitely an art form to collecting. It took me a little bit of time with Ricky's guidance to getting adequate pap specimens. Even when we're just addressing self-collected specimens, I think it is somewhat challenging. You really do have to use some pressure to get all of the walls of the anal canal. And also I've noticed that patients who have a really tight sphincter, it's hard for me to collect those cell samples, but you do not have to have glandular tissues to have an adequate pap.
Pat, did that answer your question?
I just wanted to say that it happens, to everybody. I recently had that also on 2 patients in the clinic, and it's just sometimes, as Maza said, if the sphincter is so tight, it's just really hard to get to the walls of the anal canal, and then you're just swabbing. But yeah, so the transition zone doesn't have to be present. If sometimes the lab already says, predominantly anucleate cells, and that's not a good swab. And then also I think that the HPV tests may also not be reliable in that setting. So if that's the case, and it's the majorly a pap-based, kind of triaging for screening, I would just repeat it at some point. Okay,
thanks so much. Okay, so Randy, why don't you go ahead and share your screen? We can go through how to collect. And then I can show some cases and then we can have some time for discussion, more discussion. And please, for people who have other questions, put them in the chat in the meantime.
Maza, are you able to stop sharing your slides? please?
Yeah.
And then I'll. Thank you. And then so this is available on the Bartlett intranet site too for people to look at. And so Joyce and I kind of made this from the NIH DHHS guidelines and just made it slightly easier for people to follow specifically for Bartlett. So because we do have HRA available, luckily, we don't need to follow this side. But you know, asking patients about symptoms and collecting the anal pap if they're in the right screening group, and then performing the DARE is the flow that we would recommend. And sorry, multiple slides. And then for ordering the test, it is very easy now in Epic. If you just type anal pap, these two options should come up. And we kind of feel like it'd be better for everyone at Bartlett to just go ahead and do the co-testing with HPV that's able to do the genotype for the high risk if it's 16 or 18. And just if you're going to collect anal pap to always do the co-testing. But the option is there to order it without, but we're kind of recommending that everyone go with the co-testing option. And then if someone does meet criteria or you want to refer them for an HRA, like Maza said, the order, you can type HRA into Epic and the order will be there. And I have never had an issue with this. All of my patients have been reached out to just by putting the order, and they've all been scheduled very quickly, which is great. I do sometimes give people Tanisha's number still and just tell them if you haven't heard from anyone in a week or two that they could call, but no one that I know has needed to do that, which is really nice. And this is all for HPV related disease, but if any of your patients have other anal disease, like fistulas or anything, it would be better to not send them to the HPV clinic and refer them to colorectal surgery at Jayhawk. And then this is.
I'm sorry, Randy. I just had a quick question about scheduling. So I've been telling people to call your office. Is it better just to have them wait to be called and then only call if they don't hear from somebody?
So Tanisha does a pretty good job at calling patients within a couple of weeks, and she's got but she does have a long work of calls. So even for myself, I give out my contact information for patients, and I say, if we don't call you in a week, call us. So she has no problems in reaching out to patients.
Fantastic, thank you.
Yeah, I think she's doing great, Maza, because I've never had an issue. And so then when you get the results, eventually now, if everyone is going to do co-testing, we'll be able to just follow the right side, but we still have a lot of patients from before who may have only had cytology. But this algorithm is there. I know there's lots of different guidelines, but we kind of felt like just to have it easier if you just want to go and go to this PowerPoint and follow the DHHS, that may be easier for most people. And then, we are able to do the genotype to say 16 or 18. So we're not in this category, but otherwise you should be able to follow this pretty easily. And Maza kind of already went over it. So I think the cases may be more beneficial than me going through all the steps here. And this is also on the PowerPoint. If people want to, there's a link to a YouTube video to watch to help and more instructions, like Maza explained for everyone.
Great. Thank you so much, Randy. And yeah, we are really fortunate to have this expertise here at Hopkins, and really one of the few places in the state where there is this level of expertise. Also at University of Maryland, there's a physician there who's doing HRA, and then Ricky and Maza here, and Bridget. And then there's some other providers in the state as well. But we really need to increase capacity across the country, given the rates of anal cancer. And now with this anchor study, and, obviously more research and studies need to be done. But we know that treatment is effective in preventing progression to cancer. Ricky, you have your hand raised.
Yeah, thank you. I just wanted to, in addition to like that initial referral, just, add to what Randy said and maybe we can also discuss whether that is, clear advice or not clear, right? Because we've already seen a lot of patients, I assume, and we usually have a follow-up plan. So I think each of us is doing it slightly different, but in general, we do put a note in the in the chart on the follow-up plan and the discussion with the patient, and whatever, and if they need to come for treatment, we usually schedule them immediately. And then, but for example, we would also put in should return for 6 months and should return in one year. Many people who don't need intervention come back after 1 year, right? And I just want to ask whether there are any questions on those kind of management consideration. Usually, I think we try to CC the primary and or the HIV care physician, and then also kind of and I think Maza too. We share that with Tanisha. But for example, for the 12-month out, I'm not sure whether that's reliable. So we would also kind of rely on your collaboration there to check in with the patient like a year later, right? Is there something on the books for that repeat HRA? So just seeing whether there are any questions on that communication with regard to the follow-up care once we evaluated the patient.
Yeah, I mean, personally, you all have been amazing collaborators. And whenever I have a question, I have reached out and you've been super responsive. So I don't know if others have questions about any of this part of the process, or any difficulties with referrals, things like that. We can leave it for some more Q&A on that piece. Yeah.
I'll just say, Ricky, I agree with you that that's a point where there sometimes is drop off, and it's on the patient side, not really necessarily on your side. So it is something I try to make sure to go over to encourage people to, and then I'm sometimes a little unsure if they've either missed a schedule, if I should just put another referral in, which is what I usually do, figuring it will trigger Tanisha to call them again. But I think that does sometimes happen. People go, they get the treatment, but then their follow-up sometimes isn't as tight.
Yeah, I think, it's a collaborative effort there between all of us, the patient and, Tanisha, to make sure, the follow-up is as consistent as needed.
Yeah, and I think it's an important point too, because we do have a lot of patients with high-grade disease with AIN 2 and 3. In the anchor study, about 50% of those patients, there was 10,000 screened, 5,000 ended up having biopsy-proven HSIL, and that's our experience. There's some variations, but that's our experience too. It's an office-based, the standard of care is an office-based evaluation, and it's an uncomfortable examination. So sometimes once patients are done their treatment, they don't want to come back again. But there is, I'd say from my patients, there's about 20% of patients who, despite aggressive treatment, will still have persisting HSIL too. So I definitely don't want those patients to fall in the crack. And like Ricky was saying, we don't want any interval cancers to develop. And natural history is about 10% risk with high-grade disease of developing cancer in about a 5-year time period.
Jean, I see your hand raised.
Yeah, I just, the follow-up, I'm still a little confused on the follow-up. So do you want to see all of your follow-ups for HRA or just the HSILs? Because we can certainly repeat the anal pap in a year after they get it, especially if it's normal or it's a low grade. So if you could just like send an email that specifics, we don't want to overwhelm you guys either. So it's probably, we have the patient there. If it's just a matter of getting a repeat anal pap, we're happy to do that. But I also don't want them to miss important follow-up. So I'm just gonna, and a lot of this correlates to what we do in GYN anyway with COPO. So, but things are a little different with anal dysplasia. So I want to make sure that I'm following up the way I should be.
I would say overall the patients with HSILs are the ones who need the continuity of care, for low grade, especially for persisting low grade disease. I've had patients that have come a couple of years now. This is my third year practicing, so I've had patients that have come a couple of times now with persisting, low grade disease. And so, depending on their risk factors, I do counsel them to, go back to their primary, do another pap test in a year from now.
Yeah, I think it's an excellent question. I also think that the guidelines are not, it's a little bit individual for each, a patient if they have LSIL and, for example, some HPV, let's say other high-risk HPV or whatever. I agree with Maza. I would always see a person back at least once because HRA, to be honest, it's not 100%, right? It's a difficult exam. There can be small lesions that are missed. So in that setting, if somebody who's immunocompromised, if they have LSIL, I would definitely see them back to make sure nothing was missed, right? Like the year later. There are, I think now with the help of the HPV, tools, there are some people, I think, where we can start, kind of, as Maza says, right, phasing them out from screening or like then really referring back. And I recently just, this week I talked to some people where I suggested that in my note too, right? If the patient and you feel comfortable, you could just do, and PAP and then HPV next year and not necessarily refer them back because they have been shown, as Maza said, like for a couple of years, free of disease with an HRA and anal cytology, but I would never do that for somebody who's the first time with an LSIL. There's also not definitive knowledge on the LSIL to HSIL progression in anal disease. So those people I would still, do surveillance every year. And HSIL in general should obviously come back 6 months after treatment, to make sure that they don't have persistent disease.
Thank you.
So
That's
in
very
general, I
helpful.
would try
I'm
to
sorry.
put that in the note. In general, I try to put it in the note. And then again, like if there are questions, just reach out, but I think it is a little bit patient provider for now discussions on whom to phase out of screening or extend screening intervals. There are really not enough good data on that.
Yeah, so that's very helpful. And I can tell you from the cervical dysplasia side, we have a lot of persistent LSIL. So at some point we may want to regroup and decide at what point do you just,
Right.
how often do you do this procedure before they want to
Right.
kill you, right? We get that with COPO as well. So thank you very much.
Right. Yeah, it's a combination of factors, right? Persistent LSIL, no HPV 16, 18 positive, those kind of things, right? That come together.
And
So it's
their
very
risk
individualized at that point.
and their risk factor. I'm sorry, and their risk
factors.
Yeah, for example, I have a patient today, who's HIV negative, sarcoid, and she's 10 years on her chronic corticosteroids, and now she's got a lot of HSIL. So it definitely is individualized, and we try to either put a note in or I try to do quick video visits to follow up the patients and put a recommendation, but I agree with you, like there's not a lot known about the natural history for anal and HPV disease, and we have guidelines on when to start screening now, so that's wonderful. But we don't have any guidelines after that. Ricky and I are on a committee that's looking at dissemination of information, and they told us, right, Ricky, that it took 30 years for cervical screening guidelines to get disseminated. So it's a transition for me too.
Yeah. There's a question in the chat. Yeah, so Jill Crank brought to my attention that for patients for whom we have to use LabCorp, when we're ordering both anal cytology and HPV co-testing, for some reason LabCorp is only at least sending us the HPV test results. So I've reached out to the point person from Hopkins who interacts with the LabCorp folks about this issue. Unfortunately, Jill, I don't have any updates at this point, but that is being worked on. So yeah, I don't know, Maza and Ricky, do you ever have that? Are you having to send people to Emily, your hand is raised. Yes.
I do actually have an answer for that somewhat. I
Okay.
looked because I was having the same issue in the county program, and I looked in the LabCorp code that was associated with the co-testing with the anal pap was actually only linked to a LabCorp HPV test. But the anal pap without HPV testing was in Epic was linked to the LabCorp code for just anal pap testing. So I reached out to IT, and they did put in 2 separate orders for that in the LabCorp system, at least on the computer. I haven't talked to someone. It doesn't look like there exists in their order catalog a co-testing order by itself, but there is now in Epic 2 separate orders. There is the anal pap without HPV, and then there is an HPV high risk with HPV 16 and 18 rectal source LabCorp specific order. And if you order both of those together, you will get both results from LabCorp.
Okay. Okay. I'm going to loop you in, Emily, to an email because I'm not sure who you spoke with, but the person that I've been communicating with had not resolved it. So thank you so much. So it sounds like Jill will need to put in, even though it's 1 specimen, we'll need to put in 2 orders, both the cytology and the HPV. Okay, great. Okay, I am gonna go to one case. We have about 10 minutes, and I think one of the questions that has come up is just like when to start, right? So the guidelines are saying 35. Before we had good data, we were screening. I'm sorry, Laura, I should have let you know. So this is just an example, and I know Ricky, you and Maza, we have spoken a little bit offline about this, the younger people who, well, I think there's a couple of things. One is just in general, many of us are just in the habit of if somebody has HIV, we're doing anal pap testing. But then this is the case of a woman who was diagnosed with HIV at the age of 20, has had some HPV related disease, has had significant immunosuppression, and has had highly abnormal high-grade anal dysplasia, has really yet to have the opportunity to get an HRA because of some of the issues that we've talked about in terms of, competing priorities, getting to the clinic, those kinds of things. And, they did receive the HPV-9 series. And maybe just a conversation about, the guidelines saying age of 35. Why is that? What about younger people? And then, maybe also thinking about this particular case where you had somebody who was tested starting at a younger age, still now doesn't really meet the criteria for even screening. So maybe some discussion about that, Maza and Ricky.
I mean, it's tough. I mean, there's a study that was done at Sinai a couple of years ago. It was a chart review on their younger patients, so under the age of 35, to see if any of the patients developed cancer, and none did. I know, even Sandy, who worked with us before, Ricky, we all have a handful of patients that are under the age of 35 who've had anal cancer. So I think some of it is just, deciding about how high risk the patient is. I mean, you gave a lot of reasons that they're, they had their CV4 nadir is low. They have already ongoing AIN3. I would refer this patient for an HRA.
Yeah, I probably agree. Like, see, it's hard, and that's where this kind of initial step to screening, right? For any cancer screening, it's just like you gotta think about the next steps in case something is positive, and this kind of risk-benefit assessment for the patient where that comes in. It could be obviously that somebody else started that initial screen, but I think, yeah, these are the initial conversations, right? Do we start this now? Do we start it later? And what do we do if there is a result that would request, would kind of, like usually lead to a referral for HRA? I think this is something where, I think the patient should also, as much as possible, understand the pros and cons of starting HRAs, and from there on, right, having maybe treatments versus waiting until age 35. But that means also you wait there with a potential abnormal result, right? I mean, I think everybody can think about that little bit of, how would you do that, for yourself with a colonoscopy or with a mammogram or what else, right? Like, that's just the uncertainties of cancer screening, benefit risk. I mean, I agree. If the patient agrees, send her to us, and then, we could take it from there. But oftentimes our hands are also tied, at that point. Like, then we find HSIL, which is very likely here, right? The anal pap has HSIL. You have to find HSIL on biopsy. That means we have to treat in a way, right? And then how often do you do that? And certainly we have been through these cases, and I've discussed it with patients, and then I think the majority decides to be treated.
I see.
And also,
Oh, sorry, go ahead, Mom.
Also the younger patient population, like for me, the younger folks are always the more difficult for the HRA. They're nervous, their sphincter muscles are very intact, and so the procedure is uncomfortable for them. They're going to need required repeated treatments, and so it's tough to know what to do with those patients.
Eileen, I saw your hand raised.
Yeah, I was just wondering if you could comment on, like, when you think about a mammogram and the risks being unnecessary biopsies and mental stress and whatever, or a colonoscopy and the very low risk of perf and, the nightmare that is the prep. But what do you tell patients is the risk of HRA and treatment? Is there a risk of like incontinence, of like, what are the types of things that you discuss, or is it just pain?
No, there's definitely risks. So the risks of the procedure are bleeding, infection, and damage to the sphincter muscle. You can get fecal incontinence and anal stenosis for sure. That risk is really low. I quote a 5% risk. We've treated, I think I had to keep a log initially, more than 500 patients, I've done treatments for, and I've never had any problems. I've had one patient, and it was Ricky, it was when I was training with Ricky, one patient that had diffuse, HSIL. They required multiple surgical treatments, multifocal disease, and it was an older lady. And so when she came back and saw me, I could tell that this, the sphincter tone was a little bit, tighter. And when I asked her, though, she had no, she didn't have any problems with constipation. I just noticed it because I know her, her anatomy. So I would say the risk is really low. There is a risk, but it's more for, multifocal multiple treatments, a lot of extensive disease, but we haven't had any, of course, the risk is not zero. Even in the anchor study, they had, infections and abscesses, although they reported low adverse risks, it's not a zero risk. So.
And Matthew,
Yeah, I mean, I
you
have to say,
I'm sorry.
just briefly, I have to say, I've never really seen like, especially after what we do in terms of the office-based surgery is sometimes a little bit different, but I have really not seen necessarily a lasting physical damage, but it is, even though I've did once a survey at the University of Maryland on the acceptability, and in general, we had actually very high patient acceptability. Obviously, that's of those patients who show up to an anal cancer screening clinic, but there is still a little bit of a psychological stress factor too. And sometimes it also depends on the very specific experiences, people had. And I think it's that part of it is not necessarily to be underestimated. And some people, especially, some people, to be honest, that sometimes also are referred to us, from other providers, like they did have a little bit of a traumatic experience, or they had, maybe the expectation was not set properly, for example, about the impact on, your maybe sex life after the procedure, right? That you can't have maybe sex, receptive anal sex, for a couple of weeks until you're fully healed. And people may just perceive that, as obviously then a change of their life, right? For at least for some time.
So I see we're at the hour. I can stay on. I don't know if Maza and Ricky, you can stay on. There's a couple of other questions and comments, but just want to thank you so much for your expertise, your leadership, amazing resource. And I think for us as providers, like we just want to always offer the highest level of evidence-based care, and you allow us to do that, and also helping just on a general level, right, in terms of where the field is a really important area. So thank you so much.
Hi, can I ask you a quick question? I'll be brief. Is topical GTN of any use?
I saw that come in the chat. I have never used nitroglycerin during an HRA, and I don't know of any protocols using that. I mean, it's to relax the sphincter muscle and make the examination better, right? I definitely think that there is room to grow in in the discomfort that my patients experience when I perform an HRA. There are definitely folks who use like compound pharmacy for like bupivacaine, so that's something that we should work on. Better analgesics, or even like a little bit of Ativan with the procedure. Just ways to make the procedure better. But I don't know of anything about using nitroglycerin. But that's a good point. I mean, I have room to grow on this area. So it's definitely something Ricky and I should address.
Thank you. Thanks so much. And thanks for the great talk and the great support, just as Joyce said.
Jean, I see you have a,
Yeah, I just want just a quick comment about the patient who was a no-show for HRA, and drilling down why they don't go, and remembering we have resources in the clinic, like transportation. Like a lot of my women, I just automatically refer them to Tasha to get them the Uber or whatever we're using right now, so they get over there, because that's a big barrier for our patients. So I just wanted to make sure we all remember that. That was it. And thank you so much. This was very, very helpful.
and then
just one question now, in the chat.
Yes,
I would suggest yes, and I would suggest to
so
go
can
by
you
the
repeat the
guidelines.
question, Ricky? Can you repeat the question in case people aren't seeing
So
the chat?
it is a question about the risk group. Should we be screening our non-MSM men and all our women? I would suggest yes, and I would suggest to go by the guidelines. Now also the IAN's screening guidelines have a very nice risk-based recommendation for screening. that also gives you the numbers in terms of incidence numbers. It's based on incidence numbers, right? So I would definitely suggest to follow that. It is also age-based then, depending on risk groups. It's either 35 or 45. And definitely, see, we have actually a lot of women. We are obviously at Hopkins now because we are not linked or embedded in the Bartlett Clinic. I mean, I was, in the University of Maryland, right? The clinics are embedded in the in the HIV care clinics, but we see a lot of patients now that are not, living with HIV and have other risk factors. And we have actually a lot of disease also in women with and without known risk factors. And obviously, overall, the total number of anal cancers in the United States is higher in women than in men. It's obviously very different per risk group in terms of incidence, but the majority of anal cancers in the United States by number is in women.
Okay, thank you. Okay, and then our testinate, really exciting. I know just sort of Sandy had, there had been some patients where she had some really remarkable outcomes with that. So you all have that as a study now, currently?
Yes, so it's a compassionate use trial. So we're working with Connie Trimble. They are actually doing the phase 2 study. I think they're just doing it in a private clinic. At last I heard maybe in like Vegas or New York, but based on the data from the and Ricky was part of that study. I think maybe you too, Joyce. I don't remember, but it was before I was before my time. But because of the good results with efficacy, although that wasn't the primary endpoint of the phase 1 study, the FDA has agreed to a compassionate use trial. So we're recruiting 10 we're almost at 10 already, but 10 patients with refractory disease, and then once we get the results from those patients, and they're also going to be looking at some of that phase 2 data too. I think that we can get the trial expanded for more patients. That's the goal.
Cool. Well, thank you so very much again, Maza, Ricky, Randy, and yeah, we'll definitely have you back. So have a great weekend, everybody.
Thank you
Bye.
for your collaboration on this. Yeah.
Thank you for your help, Ricky, with the presentation too, as always.
It
Have a
was
good weekend. Happy
fantastic.
Thanksgiving. Yeah.
Do you mind if could we
Oh,
share?
sure. Yes.
Okay.
Yeah, no,
Awesome.
yes. You want
Okay.
do you need a copy of the slides or just the video? What do you need?
The slides would be great. Yeah.
I'll send it to you.
Okay.
If
All
you
right.
send me just also, Joyce, Maza, if you send them to Joyce, you can send them to me and I'll put them on the CFAR site as well.
Awesome. Thank you. All right. Take care.
Good seeing you. Bye.